respected chairman, co-chairman, my dear friends, dear viewers. At the outset, I sincerely thank the organizing committee for having given me this opportunity to meet you and probably share a very interesting topic, the novel therapies in LDL cholesterol reduction. So I will take you through a little bit of introduction. I'll touch upon the newer agents and also talk a few words about the future drugs in pipeline and would summarize. As you know, ASCVD still remains the major cause of mortality in developing as well as the developed countries. And LDL is a well-known risk factor for ASCVD, and hence almost all guidelines recommend to reduce LDL as low as possible. The use of conventional therapy including statin and ezetimibe is quite good and efficient. However, it is limited in view of poor compliance and intolerance. And therefore, newer drugs are sought after to tide over the current crisis and limitation and also achieve our aspired LDL level reduction and also reduction in ASCVD levels. The newer drugs I'm going to talk about are the PCSK9 inhibitors, the bempedoic acid, and the INCLISIRAN. So we will take up one by one. What is this? This is the pre-protein convertase cyptolysine kexin type 9, which is a hepatic protease. It internalizes the LDL and its receptors and destroys the receptor, and hence the recycling of the LDL receptor is reduced. By inhibiting this with a monoclonal antibodies, this is prevented and recycling of LDL receptor is restored and increased. This increases the LDL removal from the blood, thereby reducing the serum LDL levels. Alirocumab and evolocumab are the PCSK9 inhibitors. Just look at the left 1/3 of the panel. This is a normal hepatocyte with an LDL particle binding to its receptor, now getting internalized or endocytosis. Then a clathrin coat has been given, and later on the lysosome starts digesting it and then disposes this cholesterol in the bile. However, the LDL receptor is left free to be recycled out to the surface, thereby it again binds a LDL molecule and takes it inside. When the PCSK9 is dominant, it binds with this LDL and LDL receptor. The same thing happens by internalization, clathrin coat, and metabolization of the LDL, but the LDL receptor is destroyed, and so there is no recycling of the receptor. There is a lack of LDL receptor at the periphery. When you have an antibody attached, which monoclonal antibody which gets attached to this PCSK9, it prevents the binding of this particular molecule PCSK9 over to LDL and the LDL receptor. Thereby the normal function of disposal of LDL happens, and the recycling of LDL receptor is also occurring normally, and much more reduction of LDL is achieved by this process. Alirocumab and evolocumab are the two drugs which are available, of which evolocumab is available in India, which is marketed by Reddy's Lab. However, it is an injectable form and it is available for our use for a subcutaneous injection, given once or twice a month, and the main action is reduction of LDL. The side effects are similar to placebo, and the problem occurs only at the site of injection. No increase in the new onset of diabetes or worsening diabetes, which is little common with the powerful statins, but here the cost is a limiting factor. It goes up to 30,000 per injection. Looking at the evidence of this particular molecule, the 4-year trial, which is a trial involving 27,000 and odd patients who have an established CV disease, and also they have some problem related to MI, post-stroke, or a symptomatic peripheral arterial disease, already on statin therapy or statin plus ezetimibe with a LDL level equal to or more than 70 or a non-HDL level of equal to or more than 100, they are randomized to evolocumab as well as the placebo. And what are the results? it is quite obvious the drug arm or the investigator product is definitely superior than placebo by reducing all complications from death, CV revascularization, myocardial infarction, and so on and so forth. So this not only stops with that, but the atheroma volume is decreased by about 0.95% in the evolocumab group, whereas it is only 0.05 in the placebo group. Not only the atheroma volume, but also the plaque regression is around 64.3% when compared to 47% with the placebo group. So the conclusion from this study was, among patients with angiographic evidences of CAD, chronic statin therapy, the PCSK9 inhibitor evolocumab resulted in greater change in percent of atheroma volume and a greater proportion of patients with plaque regression. Where do we position this molecule? This is positioned in statin intolerance group and very high LDL levels with more than 190 despite statin or ezetimibe. And familial hypercholesterolemia is an absolute indication for this particular drug, and whenever there's a poor compliance with statin. The second drug, the bempedoic acid, is ATP citrate lyase inhibitor. This inhibits the ATP citrate lyase, which is an upstream coenzyme for HMG-CoA. By that, it can be even called as a brother of HMG-CoA or a brother of statin, and this decreases the cholesterol synthesis, and this also activates the AMP kinase in adipose tissue, and this is not present in the muscle, so the myalgia is little less. This is a hepatocyte wherein you have the citrate, which is to be converted into acetyl-CoA, and this is blocked by this bempedoic acid. And the HMG-CoA reductase prevents the HMG-CoA conversion to mevalonic acid. Ultimately, the cholesterol formation is reduced, so more number of receptors are seen in the periphery, taking up the cholesterol, LDL cholesterol from outside into the hepatocyte. So upregulation of LDL receptor, increase in LDL clearance, and also a decrease in the plasma LDL cholesterol. How do we position this molecule? This is a molecule which is given orally, 180 milligrams per day, and long half-life. No adjustment is needed even if the eGFR is low, and first-in-class molecule, and it enhances the activity of AMP kinase 2. Offers other reduction in total cholesterol, LDL cholesterol, non-HDL, apolipoprotein B, and also hsCRP. Of course, little bit of nasopharyngitis, myalgia, and gout are reported in the clinical trials. What about the meta-analysis? All these trials favor the bempedoic acid, favorable when compared to controls. And where do we position this molecule? So statin-associated muscle symptoms like myalgia, as well as an alternative to PCSK9 inhibitors. The third drug which I'm going to tell you is about INCLISIRAN, which is a PCSK9 destroyer or a degrader. So this is an antisense oligonucleotide which binds to the PCSK9 mRNA. This causes degradation of this mRNA, and hence the PCSK9 is reduced. This results in increased LDL receptor recycling, thereby reducing the LDL levels in plasma. So this is the INCLISIRAN molecule, which just sends in the strand, the antisense oligonucleotide, and this binds with the PCSK9 mRNA. This is the binding, and after binding, it starts degradation of the PCSK mRNA, thereby the production of PCSK9 and the synthesis of the PCSK9 and is reduced, and thereby you have little more freedom for the receptors to remain and go for recycling and are much useful in reducing the LDL receptor. The studies show that there's a durable and consistent effect of over 18 months. The meta-analysis also shows that there's an improvement when compared to placebo in the INCLISIRAN group. Where do you position this molecule? This being a long-acting drug, once a day, once injection in a frequency of 90 to 180 days. But FDA approval has not been obtained so far. Minimal side effects like injection site reaction, but long-term data are not available. This is a better alternative to PCSK inhibitor in terms of efficacy and the injection frequency. When you compare all these new drugs, there's a reduction of 30% in MACE, as well as there's a correlation between LDL reduction as well as MACE prevention. Now going into the future agents, the angiopoietin-like 3, the Pelacarsen and others. We'll take up one by one. Angiopoietin-like 3 is a liver-derived circulating factor that inhibits lipoprotein lipase. We may call it as a hormone-sensitive lipase. So this is present in the tissue, particularly in the adipose tissue and muscle tissue, wherein the triglyceride or the chylomicron is opened up, and the free fatty acid is taken into the tissue. So when this happens, there will be normally a good reduction of LDL and triglyceride. But when this particular chemical is there, what happens is it causes damage of this particular LPL, thereby it causes a rise in the LDL and triglyceride level. So when this is suppressed, then you get a reduction in LDL and triglyceride. And the way of suppressing this particular molecule is again the antisense oligonucleotide and antibody-based targeting of this molecule prevents the action of ANGPTL3, thereby lowering triglyceride and LDL cholesterol in humans. So this is an LPL molecule which is inactivated by this, and once this is suppressed, you have the normal function disposing of the triglyceride and chylomicrons in a normal way or better way, which results in the reduction of LDL and LDL as well as triglyceride. What is this next drug? Pelacarsen. This is again a hepatocyte-directed antisense oligonucleotide to apoprotein A, the LP small a. And this targeting the LPA gene messenger RNA in the same way as what we did for the PCSK9, and which is done in patients with ASCVD risk. And this is safely and dose-dependently decrease LPA by about 35 to 80% in initial trials. Even today, we don't have a good drug to reduce LPA except for exercise and to very little extent the niacin group. It also reduced the pro-inflammatory gene expression in monocytes of these patients. As you know, the monocytes get loaded with the fat, become the foam cells, and they dig the endothelium and go in between and produce the atherosclerotic process or initiate the atherosclerotic process. So this also helps in a functional reduction in the transendothelial migration capacity of the monocytes, thereby not only reducing the LPA but also correcting or arresting the process of atherosclerosis is possible with this particular drug. Therefore, theoretically, it seems to be superior than the drugs which we were talking about. The other drugs which have not come out very successfully, still dead, that clustered regularly interspaced short palindromic repeats, Cas-mediated genome editing. So primarily all these drugs are brought in by interfering with the gene of the abnormality, thereby reducing, and probably it appears to be a promising drug. It significantly reduces the expression of PCSK9 and a 45% reduction of serum cholesterol. So dear friends, to summarize, ASCVD is a multifactorial problem, and dyslipidemia is one of the factors which contribute the maximum. Statins, even today, the 4 decades old molecule is quite good, and that too with or without ezetimibe still remain to be the key weapon against ASCVD. And many of you who are old timers would know that we didn't have statin, we didn't have a good cholesterol lowering drug. So we used to give only nicotinic acid tablet. As a house surgeon, I used to write as a nicotinic acid tablet 2 TDS, and that was the cheapest tablet available those days. So it was on the domain of the house surgeon to write. So that was the only tablet which could not really touch upon the lipids nor give a mortality and morbidity benefit. But today we have statin, a wonder drug. But days to come would probably have more number of drugs, more option of drugs that could probably prevent progression to diabetes or also prevent the worsening of diabetes, and that is what we expect in the newer agents who are in the pipeline, and with promising new technology of dealing with the mRNA of the affecting problem as well as the mRNA of LPA. So in that way, probably if you could do that, we could arrest atherosclerosis and probably we will all live eternally. But that's really a wishful thinking. And that would improve and revolutionize the existing anti-atherosclerotic therapy. However, as you know, it is the time-tested molecule which is the answer for clinical evaluation and clinical usage. So may God give us a period with more number of drugs in this domain and probably arrest atherosclerosis and give the humanity a little more useful as well as a healthy life. Thank you very much, and thank you very much for your patient listening.